All right, so I see a lot of men for erectile dysfunction, and part of the evaluation is checking their testosterone. And obviously, like you said, it's advertised a lot. It's been advertised a lot, probably for at least 15 years now, because they have new medications. Well, they came out about 15 years ago for it, and that was the topical gels and Testum and Androgel. So that popularized it a lot, but it is an important thing to check. So, I mean, it's just a blood test. You check your testosterone level. We like to see it above 350. That's sort of the screening point if we're going to screen for it. But a lot of patients will come in complaining of symptoms of low testosterone, which will be low libido, low sex drive. They feel like they're not gaining muscle when they work out. They're gaining fat. They can have mood swings. And those are also red flags for us to screen for testosterone. So that's sort of what indicates us to check for it. And then if it is low, and the range, that's one thing I want to mention, the range of testosterone is very wide when you look at the labs. It can be anywhere from 250 up to 850. And the reason for that is, symptoms in men differ, depending on their level. So some men could have a level of 250 and they feel totally fine, but that could be horrible for another guy. And their levels really need to be closer to 800 in the range. So that's why the range is so wide. So really a lot of it has to do with how the patient's symptoms are, not necessarily their number, because they can come in with a testosterone level of 350 and feel horrible. And another guy could be totally normal. So that's how that works. And so we screen them for it. And then if their levels are low, we will talk to them about testosterone replacement. And there's several ways you can do testosterone replacement. There's topical gels. There's now pills that are safe to use. That's a newer way of treating it. There's injection therapy. There's pellets that we'll place in. And there used to be patches, but they recently took those off the market. So those are the standard ways we start with testosterone replacement. And what we'll typically do is we'll start them on it, and then we'll recheck their levels usually I usually check it again in about 3 months to see where they are. And then once it's stabilized, it's every 6 months we check their levels. And we'll also check some of the other blood work for men, which includes their PSA and their CBC, because that is one of the side effects when you give testosterone replacement. It can cause polycythemia, so we have to make sure the red blood cell count's not going up. And so that's sort of how it works. We also check it in men who do have erectile dysfunction. That's pretty much a standard part of the test. You can have good erections with a low testosterone. They don't necessarily go hand in hand. So that brings me to another point. So patients who come in for ED, or I always screen patients for ED because that's my specialty. So they can be coming in for BPH, stones, whatever. I'll ask them how their erections are. But a lot of times, and it's a significant number, we'll say, well, my erections aren't great, and we'll talk about replacing it. And they'll be like, well, what's the point? My spouse or partner, they have no interest in it anyway. And so I have to agree. I mean, there is not much reason to go down that road of treating the erectile dysfunction if they don't have anyone to have sexual activity with or who has any interest in it, which is a big problem I've seen recently. A lot of women have low libido too. And like I said, it takes two to tango. So if we could get that part corrected, then more men would be interested in having their ED corrected.
So that's where I come in. So women also need testosterone to have an interest in sex. Libido is controlled by testosterone in both men and women. Men have testosterone and estrogen. Women have testosterone and estrogen, but we have it at different levels. So women, our estrogen tends to be higher, testosterone tends to be lower, but we still need some in order to have interest in sexual activity. So if their partners are saying, well, they're not interested in sexual activity, they should be sent to somebody who is interested in treating women's sexual dysfunction. And I love giving women testosterone. It actually helps them quite a bit, and it can be very safe to give if given appropriately. I replace testosterone with a gel that's applied to the skin every day. A woman only needs 1/10 of a man's dose. So there are these testosterone tubes. They look like little toothpaste tubes. It's called Testim. So a guy would empty this whole tube and apply it to his skin every day. And that's the appropriate dose of testosterone that he would need. But for a woman, that tube will last her 10 days. So it's a tenth of a dose of what a man would get. So just a little pea-sized amount to the skin, and that could help a lot with their libido. There are other ways of treating low libido in women. There's two medications out on the market. One is called Addyi, Addyi, or flibanserin, and the other one is called Vyleesi. And that might be an appropriate way to treat a patient. Addyi is a medication that's taken every night, and it helps with that hypoactive sexual desire. It may take 2 or 3 months for the patient to see results, but that is a way of treating. Vyleesi is interesting. It is an injection that a woman would take maybe like an hour, 45 minutes prior to sexual activity. And it basically makes the patient want to partake in sexual activity. And that tends to work really well too. They can't have more than about 8 injections in a month's time period. But there are different ways to treat low libido in women. They don't have to just suffer through it.
I have a question.
Yes.
Do you have to monitor their testosterone levels or estrogen levels when you give them testosterone?
I don't. Not if we're giving it at these low dosages. I really just go based on how do they feel. I will never go, like I said, they're not going to empty a whole tube a day. But if you're going at low dosages, there's really no need to monitor. But you do say, you tell your patients that you do need to be careful. There are potential side effects, like they can grow hair in parts of their bodies they don't want to grow, or they can develop acne, or, there could be some hair loss. Or if you're at really high levels, which you shouldn't be at, you could have things like a deepening of the voice, which is a permanent change, sadly, or the clitoris can actually enlarge. And that's also a permanent side effect. So as long as you stay low, you're good.
Yeah, I do that for men too. I always ask men, I'm like, they'll come in for a low testosterone that their primary care doctor checks. It's 300. And I'm like, well, how do you actually feel? I mean, if they feel fine, you don't have to replace it, because there are side effects too. For men, you have to monitor. You have to monitor their PSAs. You have to check their CBCs. And I mean, if you feel fine, there's no point of taking this drug unless you really need to. So that's a lot of it, how you feel.
So low T, I think, is similar in both men and women, right? It's that low libido. And Dr. Kaplan already went through what men sort of feel with low T. With women, it's really just sort of low libido and maybe decreased sense of well-being. Low estrogen, well, you don't just get to low estrogen. You go through something called perimenopause, where a woman's hormones start to change. During perimenopause, which honestly can start as early as 35 and go through, 55, every woman is different. But symptoms of perimenopause can include things like hot flashes or difficulty sleeping, mood swings, hair loss, skin changes, overall not feeling well. But once you start to feel those side effects of perimenopause, you can treat them if they are bothersome enough. So we do have hormone replacement therapy that can help a woman sort of go through a more smooth transition if they choose. It's a very personal decision. Some women just want to go through it the natural way, but some it can be really bothersome for them. And so if it's affecting their quality of life, they can reach out to their healthcare provider, somebody who is educated and is interested in replacing women's hormones.
So my question for Dr. Taghechian was, in my training and after residency, it seemed like most women were all getting Premarin or Prempro replacement. And then in the early 2000s, something changed. And primary care doctors and gynecologists, they just stopped wanting to replace
That's
it.
right, yeah.
So what happened with that?
So it all stemmed from sort of early interpretation or maybe misinterpretation of the Women's Health Initiative study. The Women's Health Initiative study is actually still going on, even from those early days. They never stopped the study, but it was looking at women who were on HRT, hormone replacement therapy, versus those that weren't. And in the early days, before they really had a chance to interpret the data correctly, I would say the media got their hands on some of the results, and they found, or they were claiming, that women were either dying on hormone replacement therapy or like getting cancer, breast cancer, strokes, blood clots, other things on hormone replacement therapy. So there was this big hullabaloo, and everybody just stopped. And like you said, physicians stopped prescribing it, women stopped taking it.
Yeah, they just stopped on their own.
And so it's been like this really scary thing for women to even think about hormones since that time. The good news is, like I said, the study is still going on, and now they have years and years of data on these patients, and we've had time to actually analyze the data pretty closely. And the interpretation of it is that hormone replacement therapy can actually be a very beneficial thing for women. But it makes a huge difference at what age or stage in their life you start hormone replacement therapy. So if you start a patient on HRT when they're perimenopausal or within 10 years of their last menstrual period, there are a lot of benefits to be gained. Of course, those perimenopausal symptoms are improved in terms of the hot flashes and the mood swings and the trouble sleeping. But on top of that, we actually found those women have a decreased risk of developing breast cancer later in their lives. They have a decreased risk of developing colon cancer. They have a decrease in any kind of cardiovascular related event like strokes or heart attacks, things like that. They have a decrease in developing diabetes. And of course, there's the bone health, and their skin looks better and their hair looks better. There's just so many benefits. And having said that, since people are always sort of scared of this breast cancer tie, like I said, there's a decreased risk of developing breast cancer if you start it at the correct time. That doesn't mean that there is zero risk of developing breast cancer. I mean, as an average person, there is some risk. But interestingly, it was found that the women who had been on HRT and developed breast cancer versus the women that hadn't been on HRT and developed breast cancer, the women who had been on it had less aggressive forms of breast cancer, more treatable forms. So for so many reasons, it's actually quite beneficial for women to start it. I don't want my patients to be scared of starting HRT if they want to do that. Now, we found that if you start HRT between 10 and 20 years after the last menstrual period, those benefits were like the decreased risk of breast cancer, colon cancer, diabetes. Those effects were sort of null. It didn't help, it didn't hurt. But of course, it did help those perimenopausal symptoms. So they could still continue it safely, but without all the great benefits that I just mentioned. But if you start a woman on a hormone replacement therapy 20 years or beyond their last menstrual period, that's where you run into trouble. That's where the risks actually do come into play. That's when your risk of breast cancer starts going up, or your risk of heart attacks and strokes start going up. So it makes a huge difference when one is started on HRT. So sort of the earlier you start on it, the better it is for you. And you absolutely do not want to start women who are 20 years and beyond their last menstrual period on hormone replacement therapy.
That's who've never been on it.
Who've never been on it, correct.
Okay. Similar to men and with testosterone, years ago they had studies that saying, oh, if you have heart disease, you're going to have to see your cardiologist before we can put them on testosterone. And there's a lot of mixed data on that. And now the more recent studies that have come out saying, oh, it's totally fine to go on testosterone. You don't have to worry about the heart disease. Actually, the cardiovascular risk may actually go up if you're not using testosterone, or if you're hypogonad, if your levels are real low.
Treating low testosterone can really be a life-changing experience for our patients. I have patients coming in who really they're just tired, they're run down, they find themselves having to take a nap in the middle of the day. They don't act like themselves. Their wives are like, you're moody, they're not sleeping well. They just have a hard time getting through the day. And when I hear things like that, of course, that triggers maybe we need to look at your testosterone levels. And so oftentimes, yes, it is correlated with low testosterone. And replacing this low T, which is relatively easy to do, can really make things turn around for these patients and just gives them, a new sense, a better sense of well-being. And they feel like they have a new lease on life.
Before hormone replacement therapy, it would be one of those things where you go to work and you get through the day and you come home and eat dinner and you're tired and you just wanted to sit around, and you become more lethargic, and you don't make as good of food choices, et cetera. So you see your body changing. So I decided to come see Dr. Taghechian, started with hormone replacement therapy, went through all the protocols, started out at certain levels, and moved our way until we got into a normal range. Once I got into that normal range, come home from work and still wanted to go out and run around and play and do stuff with my kids, hang out, watch movies and stay up later with my wife. I would say that quality of life definitely increased and was much better after being diagnosed and being treated by Dr. Taghechian.
So, ED, erectile dysfunction, I always tell patients, it's a multifactorial causes, and they always want to know why is this happening? What's the cause of it? And, you can't always pinpoint exactly what the cause is, because, it can be sometimes psychological. If it's a young patient and they have no other medical issues, or, and some even in older patients who don't have diabetes or high blood pressure problems, why are they getting ED? And we don't always have the answer. But we do have some workup for it. I always screen them for their medical issues, and that's probably the most important thing. You should screen them. How's their cholesterol? Are they diabetic? Are they overweight? And what medications are they on? Do they smoke? Obesity? All these things go into causes of erectile dysfunction, just like they cause heart disease. So, I'm always thinking about that when I'm talking to patients, especially when their erectile dysfunction comes on. And then, I ask them about their cholesterol and they haven't had it checked, or they haven't been to their medical doctor in a while. Because a lot of times erectile dysfunction is the first symptom of heart disease. So, and the reason for that is the penile artery is so tiny, but it also gets plaque and disease in it, just like the coronary arteries do. So that's something we always have to screen for. But after you've gone through that, and the workup, when they come in for ED is we do check their testosterone, and they don't necessarily go hand in hand, though. Like I said, you can have low testosterone, and we even have patients who are androgen deprivation therapy, have zero testosterone, they still get erections. So that's not necessarily they're not completely synonymous. But the workup, besides testosterone, we do an exam. Sometimes we'll send patients for what we call Doppler studies to check the blood flow going into the penis, and also checking their what we call a venous leak to see if they have, or if the blood is leaking out. Again, that helps us sort of get a little bit of idea of the cause, but it still doesn't really change the treatment much. You still start with oral medications for the most part. And when those fail, then we move on to other things. And as I tell my patients, it gets a little bit more invasive after the medications fail. The next things we have to offer are injection therapy. We actually inject medication into the penis, and it pretty much works most of the time. It will give you an erection. And then we also offer penile implants. The other option is it's called vacuum erection devices, which I'm not the biggest fan of, but they're sort of cumbersome, but they do help some. We use them more in patients who've had prostate cancer surgery and who know they're going to be getting a penile implant in the future. We help that for the future surgery. But those are the treatment options we have for it. And we, as urologists, we only recommend things that are going to work. And we know they're going to work. We're not there to just take their money and offering them things that, really don't have much durability. So that's how we think about it.
Yeah.
we've had different men's health clinics, and they come and they go. And most men's health clinics offer, their main thing is injection therapy. They obviously don't tell you that on the radio. They're not going to advertise you're sticking a needle in your penis, but that's what they're doing. But the other things they do offer, which are not really approved, there's low intensity shockwave therapy, and that came out probably about 7 years ago, and that was a very popular. And now it's sort of declined, so you don't hear about it much anymore. It has some durability, but it doesn't really last very long. So that's sort of why it's disappeared, because most patients have already tried it, and now it's gone. So these companies, the cash companies, aren't offering it anymore, or they don't talk about it. The other thing is the P shot, which is plasma-rich, platelet-rich plasma, and you just inject that into the penis. Again, trying to increase or get neovascularization to the penis to help with blood flow. Again, not really a proven therapy. It's something our guidelines don't really recommend, but it's out there still. And none of these things are covered by insurance, so that's the cost. Is there a downside? There's not much downside to trying these therapies, like risk wise. It's just, other than you may lose some money from it.
I think the same thing happens with supplements that you can get over the counter, like these testosterone boosters.
Yeah.
Again, they're not federally regulated. Nobody actually knows what's in them. And my suspicion is that, there's probably some Viagra or Cialis or something in these supplements that are helping patients with their erections.
Yeah, the gas station meds.
The gas station meds. So
that's probably what
they're
it
just
is.
not, you don't know what you're getting. It's not safe. So it's best to go to a medical professional, specifically a urologist, I would say, to get treated for something like erectile dysfunction. I think what differentiates a legitimate urologist from these men's clinics is that we actually have the best intention of the patient in mind. Whereas these men's clinics, I think, their number one goal is profit. They may offer some of the same things that we offer in terms of oral medication and penile injections. I think the biggest difference being we really walk the patient through things like the penile injections, making sure that they're doing them appropriately so that they don't develop, side effects or risks of things like priapism, which is that prolonged, painful erection. And I don't think the men's clinics necessarily even care about something like that. They start these men off at super high doses, and often they end up in the emergency room with priapism, because that is an emergency. It has to be taken care of on an emergent basis. And it's not the men's clinics coming in taking care of these patients. It's Dr. Kaplan and me on call going in to save these patients' penises. So you really do want to go to somebody who cares about you, and not somebody who sort of just cares about what's lining their pockets.
Yeah. So this patient, he's been a patient of mine for a long time. He had been on oral medications. He had tried all those, and they weren't working very well. And then we went on to injection therapy, and I think he either didn't like it or didn't want to do that. And finally, he's like, and he still was obviously interested in having sex. So he's like, let's just do the implant. And I was like, that's the way. And I totally agreed with him. I said, let's do it. And most patients aren't like that. They're like, when you talk to them about penile implants and it's a surgical procedure, like, oh God, forget it. But I mean, the reality of it is it's not that big of a surgery. I call it maybe a medium surgery at most. There is a recovery period, for about anywhere from 4 to 6 weeks. But after that, it works. And the satisfaction rate for penile implants is very high. So this patient of mine, he went through the process, he got through the recovery, and he's extremely happy. I mean, it works great for him, and it works when he wants it to work, and it stays hard as long as he wants. And that's how it is for, I'd say, 95% of the patients who go through the penile implant process. They're all happy with it once the recovery period is over.
My name's Norman. I'm 62. I've suffered from ED since around the age of 40. I initially experimented with online pills, got the generic kinds and whatnot. Did that worked, did that for 4 or 5 years. Then I decided to check in with the urologist about testosterone, had that test. It turned out to be low. So we got that resolved. And in doing so, I also got a prescription for the name brand Viagra. I did try Cialis first, didn't really like that. Went back to the Viagra, continued that for the last 10 years. The problems that I experienced with that, the good thing is it worked usually without a problem. However, you would have always the head flushing, the sinuses would be an issue, maybe a headache, and so on. So, and you never know if it was always going to work 100% of the time. So that was always a little bit of a downside. The doc had suggested an implant. I was reluctant at first, didn't really think that would be something that I would look into, and just put it off. I had a friend of mine, good friend, he had prostate surgery, cancer, and over a period of, he had that roughly 5 years ago or so. Anyway, he got an implant 6 months ago and was raving about it. Once I had a good conversation with him about it, then I was less reluctant to the mental aspect of the implant. The good part about what Dr. Kaplan did for me was his procedure is a single procedure above the pubic base, and he accesses the scrotum as well as the insertion of the implants. Point is, it's one incision. My buddy, he had two. He had one in his scrotum that he said it was the size of a softball for about a month, extremely painful and so on. So anybody contemplating this, I would strongly recommend a single access point for the procedure. In honesty, there was significant soreness, not no swelling, but soreness, because there's two access points on the head of the penis that they have to go in and pull the tubes up and to the tubes. So it's a foreign object in your body. I didn't have any soreness in the incision area, none in where the reservoirs were placed. The ball in the scrotum, that took some getting used to. Give anything a week and you were good to go. It's not something you want to jump off and get initially. I would think that it depends on the severity of your situation. If you can medicate it and you're happy with the results, then go that route initially. It is an invasive procedure. There is, something that's inserted in your body, which, there always is a little bit of a concern there, obviously. So, but in retrospect, my history, I went through the medications, went through that process, and came out the other end 15 years later going, okay, well, I should have done this a lot sooner.
When it comes to women and sexual health, there's a lot of different factors that affect that. We've talked about the hormonal side of things, so testosterone, estrogen, progesterone, all of these are important when it comes to interest, desire, and again, just overall feeling well. So if a patient needs help with hormone replacement therapy, that's something that we offer here. Women go through a lot of, let's say, trauma throughout their lives. Birthing babies, it takes a toll on one's pelvis, vagina, everything, bladder. And so with these changes, sometimes it can make intercourse not quite as satisfactory as it was in the past. I have women come to me complaining of vaginal laxity. They feel things are sort of loose. They don't have a good grip. There's grip strength is gone. They may have pain with intercourse. They may have vaginal dryness. So these things need to be addressed. They're not always addressed. A lot of the times I find these are ignored. When patients come to see me, they may have already seen their gynecologist or another physician, and they brought up their concerns, but nothing was really ever done about it. They're like, oh, just this is what happens as you get older. It's just something you have to deal with. Suck it up. And that's not the case. You don't have to live with these symptoms. So we do offer what I call, it's under the umbrella of vaginal rejuvenation. There's different methods of helping the vaginal lining. What I prefer is using radiofrequency technology along with microneedling to help make the vaginal canal healthier, literally turning back the hands of time to give your old vagina back to you. So with radiofrequency and microneedling, we can make the vaginal lining tighter by laying down collagen and elastin. That's what this therapy does. So that helps with vaginal laxity. Ultimately, it helps with making one more sensitive in like the G-spot area. We treat the clitoris, so the clitoral area becomes more sensitive. There's better blood flow to that area. It also helps with vaginal dryness. We're making the lining of the vagina healthier. Again, we're building it back up, and with that comes supporting better bacteria, which ultimately gives you a more healthier pH. That can help with UTI prevention. That can help with vaginal infection prevention, and just healthier cells in general, which help with providing vaginal lubrication as well. Other things that we offer that are non-invasive are something called V-tone. I describe V-tone as Kegels on steroids. It's basically this electric tampon, goes into the vagina, and it sets off electrical stimulation that causes intense pelvic muscle contractions. So these are super physiologic contractions much stronger than a patient could ever do on their own. And it's a treatment where we do the V-tone for 30-minute sessions for 6 weeks in a row. And by the end of that 6 weeks, patients feel much stronger in their pelvic area. Their organs are better supported. They feel like they have that grip strength back again. And sidebar, it does help with things like stress incontinence, which is leakage with coughing, sneezing, things like that. It will help with mild stress incontinence and get rid of that. Oftentimes, women also are just self-conscious about the way the vulva looks, whether it be something that they've struggled with from the beginning of life as early as they can remember, or something that has developed along the way, after having kids and going through perimenopause, menopause, what have you. Some of the things that my patients complain about are things like long inner labia. So we have two sets of labia. There's the outer labia, and then there's the inner labia. And sometimes the inner labia are protruding beyond the outer labia, and women can find that to be really uncomfortable. First of all, like they can't sit normally. They always have to keep adjusting or literally like tucking labia back into their underwear, or they can't wear certain clothing, or sex is uncomfortable because it rubs the wrong way and the labia catches, and sometimes they can even have tearing with intercourse. So with that, we have solutions. We can do a surgical labiaplasty where we actually trim that excess labia off. Now, listen, you can't just go to anybody to have this done. You really want to go to somebody who knows what they're looking at, who knows what structures to stay away from so that they don't cause you, even worse damage down the road. There's lots of people who offer labiaplasties, but you really have to do your homework and make sure you're going to somebody who's legitimate and knows what they're doing and is not going to make your life worse. So surgical labiaplasty can help. If it's more of like a mommy makeover situation where, just like the rest of your body where things sag and they're loose, same thing can happen to the vulvar area. And some of those same treatments that you use for the rest of the body, you can use for the vulvar area. So we do offer Morpheus, which is again the radiofrequency and microneedling of the external vulva. We offer something called Aviva Femtite, or the non-surgical labiaplasty, where we are just delivering that radiofrequency energy deeper into the tissue, so getting a more dramatic change than just sort of treating the skin. But that can help shrink the size of the labia and just sort of make everything look more firm, more tight, more youthful. We offer things like filler in the labia majora. So some women come in and say, I feel like my outer labia, they look deflated. They look sad. And so we can add volume to the labia by injecting filler. And they're very often happy with those results as well.
And so when you say the labia minora, it's like prolapsing. Is that what it's doing?
I don't call it prolapsing, but they are elongated to the point where they are outside of the labia majora. It's not to say this is not normal. Obviously, vulva come in all shapes and sizes, and I want to say everybody's is normal, but some shapes and sizes can be bothersome. People just may not know that there are treatments out there for them. Like, honestly, I've seen so many people just say, well, I just thought that's the way it was.
Right.
I didn't know that there was any treatment. So there's no conversation around it at all. So just coming in to get information is great. And if you don't know to come in for, like, if Dr. Kaplan sees an ED patient and he says, I'm not going to worry about it because my wife, she's getting older. She says it hurts. She doesn't want to do anything. Well, then it's up to us to educate that patient to go back and tell the wife, hey, guess what? Dr. Kaplan said there are things that you can do. So, like, even communicating with that person's partner and getting the message back to them is very helpful. And then that way they can both enjoy their sex life, That's not something that has to end at a particular age.
Right. I think there's two things. There's desire and there's function, and we can help with both of those problems.
Mm-hmm. And, they're just looking for, what can I do, doc, to sort of help me, get my groove back. And so we go through all the treatment options that we have. And there's so many, there's the vaginal rejuvenation that we can do. There's vaginal hormones that can come into play. If they're of, safe age to do HRT, we can do HRT. We can do testosterone replacement. We have things like the sweet spot shot where we inject PRF, or platelet-rich fibrinogen, into the clitoris and the G-spot. So there's, a lot of things that can be done to help a patient get their self-esteem back, so they're not self-conscious when they're ready to get back into the dating world and, engage in sexual activity. So that's a very common scenario that shows up, and they are so happy after all their treatments. They're like, wow, I didn't know that this is something that I could do. I'm so glad that I came. I'm so glad that I went through this. And these patients have the biggest smile on their face when they come in for their follow-ups. And they're happy, and their partners are happy because the patient is happy. So, it's really fun treating these patients.
I see a lot of male patients, and their partner just has no interest. So that really puts a damper on them. And I think what we like patients to do is they can come in as a couple. We can see them individually, and we have solutions if they, I think it would help their relationship in general, knowing that there's something out there, and most patients don't realize that. I actually saw a patient today whose spouse, she was had been on some testosterone replacement. She was fine, but he was the one having the issue. So he came to see me to correct the ED problem because she wants to have sex and he's not able to perform. So, it works both ways.
So it just starts with one conversation. Hey, honey, I went to the urologist, and he or she said that there are things that could help you. So maybe you should make an appointment. It just takes that one little conversation, and then it could really change the future course of your life as a couple.